so our next session is going to be a bit of a collaboration. So we'll first hear from Dr. Linda Laux from Lurie Children's, and then she'll be followed by Thomas Stanton from Danny Did, and they're going to give us an overview of SUDEP and of seizure detection devices. And then following their presentation, we're going to bring up two caregivers and have a little panel discussion kind of across all of their experiences with these topics.
Hello, everyone. It's very good to see you again. Again, my name is Linda Laux. I'm a pediatric epilepsy doctor at Lurie Children's, and I'm going to give a quick overview of SUDEP in patients with Dravet syndrome. I'm actually going to start with some general definitions, incidents, and then go a little bit more specifically to Dravet syndrome, risk factors, why this might happen, and what we can do. Then I'm very happy to be followed by Tom Stanton, who's going to give a more in-depth look at seizure detection devices. So I do have some disclosures of people in the last year that I've been working with for research and consultation. That doesn't really affect this talk. So SUDEP, as I think everybody here knows, is sudden unexpected death in epilepsy, and it's a death that occurs abruptly without warning or other apparent medical causes in people with epilepsy. I always explain to families that everybody has a risk of sudden unexpected death. It's just that in people with epilepsy, that risk is quite a bit elevated. Still rare in general, but it is increased. And it is the leading cause of death in intractable epilepsy, accounting to 40 to 50% of the mortality. And for people with childhood onset epilepsy in general, the median age of SUDEP was 25 years. Now, the circumstances of death is as you see. Again, the death occurs during regular activities, and sleep is a regular activity. So oftentimes it will happen in sleep with the patient prone or your child, adult prone, and that's face down. Oftentimes it is not witnessed, although in 10 to 20% of cases it is witnessed, and that's more so in kids because kids are monitored more at night. And the majority, will have evidence of having a convulsion prior to death. Now, the incidence of SUDEP rate in adults is 1 to 5 per 1,000 person years. The SUDEP rate in kids was felt to be much less at that, at 1.2 per 1,000 person years. However, recently there's been a couple epidemiologic studies from Sweden and Canada that shows that the risk might be quite a bit higher, at about 1 per 1,000 as well, so very similar to adults. Now, when I've always looked at mortality or risks of SUDEP, it's interesting they present them as a per 1,000 person years, and that always gets me a little bit. I understand just simple percentiles more, but this is done to get a time association into that. So if I say somebody has a 3% risk of something, is it in the first 10 years of life, 20, their entire life? So by saying something in per person years, gives you that time frame. And what that means when we say there is a risk of 1 in 1,000 person years is that the number of patients with SUDEP, if we watch 1,000 patients, children with epilepsy, over 1 year, one patient will have passed away from SUDEP. So that's what that means. Now, if you look at that visually, you can tell that that's a very small amount of those 1,000 persons that you're observing over the 1 year. For me, it's a little bit easier to think of, perhaps, as if we look at 100 patients over 10 years, then one will pass away from SUDEP. Those are the same in terms of the 1,000 person years. Now, if we switch to looking at Dravet syndrome specifically, then we often will look at both mortality and SUDEP together. And there actually has been a lot of papers out on this subject. So there was a really nice review recently by Joe Sullivan that looked at these and kind of correlated all the information. And what they found was that there is about 50 to 60% of deaths in epilepsy for people with Dravet syndrome from SUDEP. Mortality rate can range from 4 to 20%, and that ranges are what really depended on how long that they were looked at or studied, and those time frames were 2 to 26 years. So again, if we try to then bring it into those 1,000 person years, it's a mortality rate of 15.8 per 1,000 person years. So 1,000 people with Dravet syndrome looked at over 1 year, they will have 15 to 16 people pass away from any cause. That's just general mortality. And the median age of death for any reason is 4.7 to 7 years. Now, if we look at SUDEP specifically, there was the initial study that came out on a SUDEP-specific rate for people with Dravet syndrome was initially the study by Cooper et al., which was the 9.32 per 1,000 person years, which is quite a bit higher. A more recent study that came out of Scotland, or the UK, who looked at this, had a rate of 4.4 per person years of SUDEP. Again, a little bit more in kind of the adult epilepsy rate. There was recently a study that looked at fenfluramine for patients who had a good response to fenfluramine. Their SUDEP rate in the course of that study, so it was a short time period, came down to 1.7 years. And we're going to look a little bit in a few slides as to why that might be. Another interesting study, because one of the questions I often get asked is, when should you be worried about SUDEP in your children? And the SUDEP peaks in this one study showed a primary peak from 1 to 3 years of age, although you can look, those are the yellow bars, and the yellow bars do continue throughout all different ages. But then a second peak happens at about 18 years of age. So then the question is, why? Why does SUDEP seem to be at a higher risk for patients with Dravet syndrome? And we'll step back and just look at what the risks for SUDEP are in anybody with epilepsy. And they tend to be higher risk for patients who have pharmacoresistance, meaning their seizures are harder to treat with medicines. Also those who have a history of generalized tonic-clonic seizures, ones who are not adherent to their medicines, families that are on multiple medications, and I think this is just a reflection on the fact that there is very hard to treat epilepsy, the seizures that occur from sleep, epilepsy that itself has lasted for a long time, so epilepsy that starts in childhood, and there is some evidence that it's increased for patients who have intellectual disability. So if you look at these risk factors, a lot of these are seen in Dravet syndrome. So is it simply that Dravet syndrome has a lot of these risk factors, or is there something more in terms of the SCN1A variant? So to get at that question, we're going to step back and take a look at why SUDEP occurs. And the answer at this point in time is we do not know. That's your main takeaway. However, it is felt that it's probably multifactorial, meaning a lot of things are happening at once that causes SUDEP. First, it should be noted that SUDEP is highly associated with seizures. Again, remember on a prior slide, there was evidence of seizures that occurred if someone was found having passed away in about 50 to 90% of patients. There is a study out there that was a very important study for SUDEP that looked at patients who had died in the hospital, specifically in epilepsy monitoring units with SUDEP, and all of them had a preceding seizure. This was a very specific patient population of people being looked at for possible surgery interventions, so medications were being discontinued. So it doesn't mean that necessarily everybody has a seizure prior to SUDEP, but the vast majority do. Also realize that this does not mean status epilepticus. It's not necessarily that this was a very long seizure that happened. And again, if we look at the study of the patients in the epilepsy monitoring unit, it was not. So when somebody passes away, it is usually because either their heart stops or their breathing stops. So we are going to look at those two areas, as well as something called cerebral shutdown, partly because you will run into this if you look into SUDEP literature, so exactly what that means. In terms of the cardiac reasons, it's theorized that cardiac arrhythmias or irregular heart rates might be what's associated with SUDEP. And these are observed with people who have generalized tonic-clonic seizures as well as focal seizures. It also should be noted that genes that are associated with epilepsy are also found in the heart. They might not be the primary sodium channel in the heart, but there are the NaV1.1 proteins in the heart. Now, when we look at specifically in some evidence for Dravet syndrome, there was a patient by Lurie that in a mouse model of Dravet syndrome, and they followed a mouse that had died, they had a prolonged bradycardia or slowing of the heart rate that occurred because of an irregular heart rate because of parasympathetic nervous system reasons. And they postulated that this therefore can be a reason that for SUDEP in the Dravet syndrome population. However, it should be noted that actually the respiratory part of this mouse was not really being followed as closely, so it still wasn't sure if it was really respiratory versus a cardiac reason. Then in addition, they found that people have looked at a lot of heart rhythms in patients with Dravet syndrome, and there's not a significant amount of arrhythmia there. Now, if we look at the respiratory dysfunction, these really come in two ways. One is that during the seizure, and regardless of how a person would go to sleep, it's possible that when you start having a generalized tonic-clonic seizure, the movement will actually turn you so that you're face down. And if any of us is sleeping and we go face down and we're not breathing adequately, we have a semi-arousal, we move around, and we adjust. But if somebody is in the midst of a seizure when this happens, their brain might not be able to understand to do that, and therefore you do not breathe effectively. The second way that a respiratory dysfunction can cause SUDEP is simply stop breathing from a brainstem origin. Your brainstem is responsible for your respiratory center. It's unclear why this might be, but we do know that when you have seizures, you have an increase in something called adenosine, which decreases your respiratory suppression. And there's also a theory that you would have serotonin dysfunction that doesn't then rev up your respiratory effort. So you'll often see adenosine and serotonin linked to SUDEP. And again, there are evidence in SCN1A mice that died after spontaneous as well as heat-induced seizures secondary to apnea and then progressive bradycardia. Now, cerebral shutdown is something that we observe in the epilepsy monitoring unit, that after a hard, long seizure, there's often a flattening of the EEG, and that's what that EEG picture is there. I don't think you need to be a physician to see that there's a bunch of lines and then it's flat. And it's thought that after a seizure stops and you get that flattening of the EEG, your brain does not functioning as it should. And therefore you can have some of the respiratory and the heart issues follow this. And this has become a biomarker for SUDEP. So if you have this flattening or suppression after a convulsive seizure that lasts greater than 60 seconds, then you are at a higher risk for SUDEP. And again, this kind of cerebral shutdown has been seen in Dravet syndrome mice as well. Now, I do want to pivot for just a moment in terms of how we try to get information to families about SUDEP. So I looked to see what was actually out there in terms of recommendations by our professional societies, and AES stands for the American Epilepsy Society. And they came out with a counseling guides in 2019 and scenarios in which SUDEP counseling should be considered, which you can read there, of which Dravet is specifically listed. But the end of that list is simply anybody with a new epilepsy diagnosis. And I know of families who do not have long epilepsy or very hard to treat epilepsy who have died from SUDEP. So I think that is the appropriate recommendation. They then go on to say that this information is given, it's very individually given depending on circumstances and many other things. But they note at the end of that survey data demonstrates that the majority of patients with epilepsy and their families prefer to be informed about SUDEP risk by their providers. Now, if we look specifically on this risk in terms of epilepsy, in terms of Dravet syndrome, this nice study came out in 2023, and I think it might be a little bit hard for you to read because it's hard for me to read up here. But generally what they're showing in the graph that's far to your left, what is in green is what families wish would have happened, and what red is what did happen. And that first graph is looking at where did they get their information on SUDEP. And the bottom line is that they wish they would have gotten the information from their physicians. Where they got it was usually patient support groups or the internet. The second group is information when the information was received. And most of the families wished it was received either at the diagnosis of epilepsy or at the diagnosis of Dravet syndrome. Diagnosis of Dravet syndrome actually was a higher rate there. But as you can see, many of them did not receive it for months or years, if ever, after the diagnosis. The next column, the third one, is simply looking at CPR training, that it can be important. And the last one I do find very interesting, and I'm hoping that perhaps the parents that come up can talk a little bit about this too, in terms of how does the monitoring help you at night? The hope is that it will detect seizures. It would possibly prevent SUDEP, but it also allows just a little bit of comfort for the family to be able to sleep, and you can see that on there, that it will allow them to actually sleep better, knowing that their child is being monitored by something more than just them being awake at night. So how might we decrease the risk of SUDEP? And number one is simply good seizure control. And this is especially for convulsive seizures. So there's an increased risk of SUDEP if there's more than 3 convulsive seizures in a year, which I would suspect that many in this auditorium here would love it if their child only had 3 convulsive seizures in a year. But that is something to strive for, to have the best seizure control possible. And again, in that fenfluramine clinical trial, where seizures were improved and convulsive seizures, they had that decreased risk of SUDEP. Adherence to medications is very important, trying to identify and avoid seizure triggers. We do know that there is a decreased risk of SUDEP for patients who are monitored. They don't really specify a lot of the monitoring, but sleeping in the same room, audio monitors, and seizure detection devices, which is going to be discussed next at length. And certainly, the Danny Did Foundation is a referral I use for every patient with epilepsy, Dravet syndrome, or otherwise, because it is such excellent information there. And what does the future hold? Well, one of the things to realize is there continues to be lots of research in this area, both by Citizens, the Cure, Citizens United in Research Against Epilepsy, as well as Dravet Syndrome Foundation. There's so much research going on. In the meantime, it's interesting that some of those genetic studies that we have looked at, both for Stoke and Encoded, in their mouse models of Dravet syndrome, those medicines did not only help the seizures, they very much helped the SUDEP that they saw in the Dravet syndrome mice. In addition, there was just a study out in 2023 that showed that increasing the serotonin in the brain in mice models of Dravet syndrome also decreased the risk of SUDEP. And this can be increasing the serotonin from a number of different ways. They looked at it in terms of 3 compounds, one of which is what we call an SSRI, or selective serotonin inhibitory. What they looked at specifically was Prozac, and they also looked at fenfluramine, and again, SUDEP risk decreased. So something to think about for the future. But certainly, if you're doing this monitoring, just like you should know exactly what to do if your child is seizing, you really should know exactly what to do if your alarms do go off and it doesn't look like your child is breathing well. And the first and foremost is just positioning. If they're on their face, turn them over. Sometimes just that stimulation is all they're going to need. And I'm sure everybody here has already seen that. But certainly, if it's something that they don't start breathing at that moment, just from stimulation and turning over, knowing CPR can be life-saving. So I just want to thank everybody here again, patients, families, caregivers, Dravet Syndrome Foundation, Danny Did Foundation, and everybody who works with me at Lurie's. Thank you very much.
So thank you, Dr. Laux, and thank you for the opportunity to be here. My name is Tom Stanton, and I'm with the Danny Did Foundation, which is a nonprofit based in Chicago. Thanks to Veronica and Mary Ann for the opportunity to be here today. Over the past 15 years, we've interacted with a lot of Dravet families, and it's really an honor to be with you. No disclosures to report. So this is my nephew, Danny. Danny did not have Dravet. He was diagnosed with a childhood seizure disorder when he was 2 years old after he had his first seizure. And he was one of those kids that had pretty good seizure control. His parents only witnessed 4 seizures over the next 2.5 years. He was the third of 4 kids. He had 2 older siblings and a younger brother. And generally fell into that camp that Dr. Laux described, where maybe not considered high risk for SUDEP. After Danny passed away at age 4, his parents saw the term SUDEP on his death certificate. They had never been counseled about it, so they were really blindsided, and we've met a lot of families who have fallen into that scenario where they first heard the term SUDEP after their loved one passed away. So our mission and our sense of urgency is really driven by Danny's story, and this slide kind of talks about how we want to engage patients and caregivers and the medical provider community to try to make progress. So this just talks about our points of focus. Our public awareness efforts really do focus on epilepsy, but also specifically the risk of SUDEP, because we know that both need so much progress. Our main niche within the epilepsy community is as a source of neutral information about devices and technologies, which we really feel can serve as a complement to medication or diet or genetic therapies or surgery. We're really careful not to pretend like these devices are a silver bullet. We don't endorse one over the other. We really just want to share information because we do feel they can add another layer of protection. So this slide shows a pretty big disparity that exists when it comes to talking about the risk of SUDEP. Last year we partnered with Duke University and other advocacy groups for a survey of caregivers to learn about who they wanted to hear about the risk of SUDEP from, how they wanted to receive that message, where and when. And the second bullet here really highlights that the community's desire to know about SUDEP is not fully being met today. There's a considerable gap. So this one outcome from this partnership with Duke was just this simple checklist of questions that could be asked by a parent on this, difficult topic of SUDEP. And this is available on our website if it's helpful to anybody here to bring into an appointment. We talk about SUDEP with families and caregivers all the time, but we always do that in the context that we know that this message would be best delivered, optimally delivered from a healthcare provider. We just really believe it builds that trust. But we'll continue to spread the message, and I think the increase in SUDEP awareness is really largely driven by our parent community asking these questions and putting it in front of our healthcare providers. This next slide just shows some examples of our awareness efforts. We all know that epilepsy is really stigmatized and not talked about by the general public very often. This slide just shows some recent examples of platforms that we've tried for epilepsy and SUDEP awareness. There's billboards in airports, bus stop displays, radio campaigns, and we've even wrapped a garbage truck. We always joke that if we can't reach you in the streets, we'll find you in the alleys. So we'll try anything. And in addition to educating, our hope for these campaigns is that it helps to erode the awful stigma that has accompanied the epilepsies for too long. So technology within epilepsy is really our wheelhouse, and it's a very fast-growing field. Again, just to reiterate, we consider devices and technologies as a complement to medication, surgery, diet, as a part of a patient's treatment plan. On this slide, you can see some of the main categories within this space. So within the surgical category, it was referenced earlier, one example being VNS or other implanted technologies like RNS. In the wearable category, some examples of products in that space would include the Embrace watch, or now currently called the Epi Monitor. There's a watch-based application called Inspire, another one called Seize Alarm, another one called EpiPal, and these are listed on our website if you want to reference them later. There's also resources that are kind of low tech, such as anti-suffocation pillows, harnesses for drop seizures that can be helpful for safety. There's a website and software called Seizure Tracker that some of you may be familiar with. So those all kind of fall into that non-invasive category, which is, as you can imagine, kind of a first line of inquiry for a lot of parents who are maybe more hesitant to inquire or investigate the surgical options right away. And then this last category, nocturnal, is what I know, my nephew's seizures were all during sleep. And I know when it comes to the anxiety that we as parents face, a lot of it is surrounding these nocturnal seizures. For the obvious reason that it's just a more vulnerable time and there's less surveillance, less vigilance. Some products in this space, there's one called the MFit, which is a very thin device that goes between the box spring and the mattress and monitors for movement. There's one called the SAMI Alert, which is a video-based movement monitor. A company called Owlet has a product called the Baby Sat that looks for changes in respiration. And then some people even employ products like pulse oximeters to monitor for seizure activity. Again, just to reiterate, this is another tool in your toolkit. It's not meant to replace your vigilance, but we do think that it can help as a kind of a backup layer of safety. We all know that caregiver anxiety about missing a seizure is really elevated during sleep. I know that was my brother's experience with his wife. They did a lot of co-sleeping, constant bed checks, and that affects, of course, your ability to get your own rest and to approach the next day. Those are all part of the same kind of vicious cycle that epilepsy puts in front of us. Most cases of SUDEP are unwitnessed. That's not always true, but it's generally the case. It was the case with my nephew. And so we really feel strongly about this concept of early intervention. The idea that if you're present, you have a chance to take action. And Dr. Laux talked about what some of those actions could be. We also use that analogy where if any of our kids are in the epilepsy monitoring unit, they're always being watched, they're always being monitored, and we typically wouldn't leave them unmonitored in that scenario. So when we go home and we leave the hospital, this concept of monitoring is still important to us as parents and wanting to know that we'll be alerted in some fashion if a seizure takes place. So the most common question that we get is, which device should we use? And the answer is, it really depends. It depends on what you're looking for out of the product. It depends on what your scenario is at home in terms of the types of seizures, how old your child is. There's a lot of different variables. This slide is just meant to walk you through some of the things to think about. And when families come to us, oftentimes there's a level of desperation or just wanting any kind of solution. And a big part of our role is just helping to pause, take a breath, and really think about how does our scenario align with what's available in the market today. Because what we don't want to happen is for a family to buy a device and then have unrealistic expectations about what it could do for them. So just thinking through about your goals for the device. Are you looking to track seizures? Are you looking to share information with your doctor? If so, how does that happen within this particular system? If you want to be alerted, how are the alerts delivered? And number 3 is a really important one, just kind of the practicality of the device. Is it worn? Does your child want to have something on their wrist? Are they old enough to have a smartphone that may need to deliver the alerts? For example, with the SAMI, where that's a video-based monitor, does your child want to be on video at night? Are they comfortable with the privacy issues involved? Number 4 just speaks to the technical aspects. We really encourage families to look through what is required to utilize the system before they make that purchase. Ask questions, reach out, test their customer service, because whatever you receive before you make the purchase is probably going to be similar to how you're interacted with afterwards. And then the last one is obviously a big one in terms of access. What does it cost? Is there an upfront cost for the hardware? Are there monthly subscription fees involved? How do those impact your budget and your finances? And that's a piece where we try to be helpful. So this slide just takes a look at some of the benefits to caregivers. The first one, I think, is really important, and that is that they're in demand. People want these resources for reasons that you've heard about today and that I've talked a little bit about. The aspect of seizure tracking, even for people who may live alone and want some mechanism to know if they're missing seizures, or certainly for parents to want to know, hey, I thought we were having X number of seizures per week or per month, and now I know we're having more or less than that. And how that may impact the information that you're sharing with your doctor, and how the doctor may be able to utilize that information to adjust the treatment plan. The timely aid, doctor just spoke about what could be done if someone were to intervene and how important that is. The ability to administer rescue medications, Dr. Smith talked about the timeliness of that and how those need to be delivered in a timely fashion. And then, these last few ones are so important, and we hear about them all the time. The anxiety, the desire for independence, the desire for peace of mind, both for the person, the child, and for the caregiver. Those are really important and can be addressed through some of these systems. And then we also want to make the case to our providers what they could gain from these systems. And the first one is just to engage and empower their patients and the caregivers into their own care. We can really have a key role in this process. The second one, obviously everyone wants a timely intervention, including our providers. The seizure tracking data, that can be really difficult for parents and patients to keep track of amidst all that you're dealing with when a seizure takes place. And then the optimization of medications, just the idea that we can be more precise, or doctors can be more precise if they have the most accurate possible data as far as how often seizures are happening. This slide just alludes to the fact that what we have today is not perfect. It's far from it. These devices are, for the most part, kind of in their infancy. They will get better and more reliable over time. There are a couple points made here just in terms of the usability, how long do the batteries last, how many false alarms are there stigmas with how these products may look, and how does that impact the person who's wearing them. And then, of course, the cost and the current lack of insurance coverage. For the most part, what's at market today, they're all considered consumer devices. Only a few have FDA approval, and they're considered as medical devices. And the lack of insurance issue is a huge, huge problem that we're trying to move forward. So looking at what's coming next, just the idea that multiple seizure types could be detected and alerted to by one system reliably. The concept of AI-powered systems where the device becomes more accurate over time is a really exciting concept. And then that fourth bullet speaks to the insurance issue, the reimbursement issue. A lot of companies who want to get into this space, innovators, startups, they struggle with the business model because there is so little reimbursement right now. How do they sustain their business over time? And I'll talk a little bit about what Danny does to try to fill that gap, but in the big picture, there needs to be more sustainable solutions. And so we were a part of a meeting recently with the FDA and Medicaid and Medicare and about 30 device companies to try to move that issue forward, because we really need to figure out how do we get some of these systems covered, the best options among them. And then the final bullet just talks about, this idea of prediction. Can we get ahead of the seizure and give a notification that there would be one that is on the horizon, and then have the ability to suppress the seizure would be kind of our holy grail. So just to take a minute here to talk about what we do in terms of access, we have a grant program at Danny Did where we help people kind of talk through their options. They can apply for funding if finances are a barrier. We have a phone call with each applicant. And then if there's a fit determined and we kind of vet out the financial need, then we'll provide a grant directly to the family that enables them to get that resource into their home setting. The family would place the order themselves. They would have the relationship with the company themselves. We would kind of just be that bridge to help with the financial part. And the reason is we really want the parent, or in some cases the adult patient, to have that relationship and to be the direct contact for all information provided by the device manufacturer. So if you have any questions, or if this could potentially be helpful for you, all this information is on our website, dannydid.org, and we've helped families in all 50 states and 17 countries, so we want to be a resource for people as far and wide as we can. I just want to make a quick note in terms of the access issue. There was a law passed last year here locally in Minnesota, which essentially says that for any FDA-approved seizure detection device, there is coverage by Medicaid. And that was the first law of its kind in the US, so it's exciting in that regard. Kudos to the local Epilepsy Foundation of Minnesota for moving that forward and getting that passed. I think doing that in all 50 states would take time and be challenging, and I think there are families that are willing to move that ahead. I know we're thinking about doing it in Illinois, but I think the bigger and maybe better solution would be if we could come up with some kind of national plan where there is partnerships with Medicaid and Medicare and other providers, other insurers, to have coverage across all 50 states. But this was exciting and really, like I said, the first law of its kind. This next slide, I apologize for it's a lot of information and hard to read, but I just wanted to make a plug for this toolkit that just came out last year as a collaboration with the Child Neurology Society and I think around 20 different epilepsy organizations, including the Dravet Syndrome Foundation. And it's a toolkit around the issue of mortality in epilepsy. So certainly SUDEP is one, status is another, and the other potential forms of mortality related to epilepsy. This toolkit is meant primarily as a resource for providers on how to have these conversations, some of the resources available to them, but also for us in the patient and caregiver community to help move that conversation ahead. So the website is preventingepilepsydeaths.org, and we think that can be very helpful. So with that, just to let you know, we're here to help. If there's families that you think could benefit from our support, that's what we're here for, and I appreciate the opportunity to be here. Thanks.
All right, so I know we're a little over time. I'm going to bump the break back because, as we have just discussed, this is such an important topic that doesn't get discussed enough. So we're going to do the panel, and then we'll go to break, and we'll make time back up at lunch. So joining us now on the panel, we have Jen Marasco-Kuhn, who is a caregiver as well as a DSF ambassador. And then we have Rich Maxey on the end, who is our DSF Faces coordinator, does a lot of support of our family community. I wanted to just start out and have, we'll start with Jen. There should be a mic there. If you could just tell us just a little bit about your loved one with Dravet syndrome and what kind of monitoring approaches that your family has taken for her seizures.
Thank you so much. So as Veronica said, my name is Jen Marasco-Kuhn, and I'm a DSF family ambassador since 2022. My husband Chris and I have 2 daughters, Maggie, who's 7, and Cora, who's 4. And Cora is our DS warrior. So we've taken a variety of approaches to safe sleep practices since Cora's been diagnosed. And I want to share that this is my family's experience, and our choices might not necessarily be other people's choices, but I think it's important to learn from each other and to take what other people have experienced and adapt it to our own needs. So when Cora was a baby, before Dravet, we had a baby monitor, just like anyone would use, and that was a helpful tool. And then she unfortunately started having seizures at 5 months. And it was a very chaotic time. We didn't get diagnosed with Dravet syndrome until she was around 9 months old. And we unfortunately had our first PICU experience. She was coded after an aspiration from a 32-minute seizure. And our whole world, was upside down. We were in the hospital for 11 days, and we were discharged with a lot of new meds, a new direction in life, a lot of new resources we were looking into. And we were graciously given an outlet, and that was our first seizure monitoring device, you would say, that we used for sleep. And it wasn't initially intended for, SEDEP monitoring, but it worked for us initially, and we were graciously given that by a friend of ours. So we used that for a variety of months, along with a baby monitor. And we slept as well as we could in a very anxious time during a pandemic. And then as babies grow, she grew out of the outlet. And so we had to look into other devices. And another DS mom, she had kind of taken me under her wing whenever we were in the hospital, and she had advocated that I look into a pulse ox, a hospital-grade pulse ox. So after a lot of fighting, we did receive that, and we started using that. And I think it is a very good device. However, for our personal experience, we had some trauma related to it. At the time of us having the pulse ox, it has a cord, and my child is an alligator, and she sleeps and turns and tosses, and I found her multiple times with a cord wrapped around her throat, and I was then scared of asphyxiation versus SEDEP. We even took the cord and wrapped it around her crib, but she is very adept at doing different things, and we still found that situation. Along with that concern, she had the sensor on her multiple times, whether it was at home or hospitalizations, and we personally experienced it burning her at different points despite different techniques given to us from families. And my child, she was very young, and she couldn't tell me, but I really think she had like a PTSD to this experience. It was causing her pain. So she'd ripped that thing off. So, we barely could get it on her. We barely could get it to stay on her. And then, we'd get her to sleep if it was on, and it would alert, not because of a seizure, but because she ripped it off. So that was very traumatizing as well for my husband and I. So we eventually stopped using that, and we still have it. I'm very grateful for it. We use it in the case of a seizure, so we can try to avoid hospitalization, monitoring at home. I've heard that there's a new wireless one available, so I am looking to work with our neurologist to try to obtain that and see if Cora would be more amenable to it. I just don't know how she's going to do still with that history of burning. And she's 4. She's somewhat verbal, but not necessarily to her own experiences. So I try to balance our need for safety with her personal, autonomy and comfort. So that's something I am looking into. But we did transition to an MFIT over the last year, and we were graciously awarded it from another family member who gives them out, I believe, once a year. She, felt our story and she gave it to us, and we've been using that, and I find that to be a comfort. It's a pad, as Tom said. It goes under her bed, and it alerts if there's any activity or repetitive movements. It has alarmed, and it hasn't been a seizure, but it's not as triggering as a pulse ox and as some of the other devices that I've heard and experienced. So we're not as reactive to it in a negative way. And if it does alarm, we initially look at the baby monitor, kind of make a decision, and then we can also go in and check. We haven't had the experience of a nighttime seizure with the MFIT. Cora typically has seizures related to illness and temperature changes. We do regular EEGs. They haven't been found to be overnight seizures. So with our family's personal experience of it, that's how we monitor it. And I am in the process of looking into a SAMI monitor for further safety. So thank you so much.
Good morning. My name is Rich Maxey. I'm the FACE coordinator with DSF. And my family's had a little bit more of a conservative approach with technology and assisting. My son is 9 years old with Dravet, and we have an older brother. He is 12. So our approach is just kind of a family effort. All eyes are on Zachary, making sure that, if he gets up, somebody kind of slides behind him and kind of follows him around, and that's just what has happened for us and how we've kind of adapted. We recently got a SAMI monitor, and that has been an absolute lifesaver. And I'll tell you why. Technology, I have an IT background. I love technology. However, my wife does not. So when you set up different cameras and set up different things, I know how to do it and I can get there. But she looks at me and that ain't gonna work. So the SAMI really simplified it for us. We co-sleep. We've done that his whole life. It works for us. He's actually a pretty good sleeper. He's a little snuggler, so that's been helpful. And we've kind of played around with letting him nap. It's just we're not comfortable with it. We choose not to. However, when he takes his naps, I turn the SAMI on, and it's very helpful. It monitors sound, monitors video, and there's some thresholds that are set. Once those two items hit that threshold, you hear an alarm, and so far it works really well. Of course, there's going to be, we've got a couple of pets in the house, so we have a couple of little emergencies to, take care of the dog that jumped on the bed. But it works, and it works well. It's simple. I have not set it up for my wife yet, but I have not had any issues with that device. The other thing that we really rely on is a pulse ox. So when Zachary has his tonic-clonics, when he goes into a postictal state, that's when we utilize just the simple little finger pulse ox just to see where his oxygen levels are at. His lips turn blue quite often, and that's really what prompted us to try and maybe get an idea of where he is. Should we be concerned? That came into question earlier today. How many times do you wait? When do you get involved? Because of the bluing of the lips, that's really, we rely on that pulse ox. I rely on the pulse ox. My wife is an RN, so she has her own methods, but for me, I do rely on that. One thing I will say, for me personally, technology can be extremely frustrating. So if you're looking into devices, I mean, they're simple aids, and it's another set of eyes, so to speak. We don't put all of our eggs in the technology basket. So it is helpful. I think everybody should look into all the options that are out there, and every option is going to be different for every family. You know, seizure dogs. We have a failed seizure dog. He's a wonderful pet. But the thought was there. And, you know, it's just picking up on those subtle little household hints, I guess, as far as are we expecting it? Is it going to happen? But there's no real technology that we can use to help us out with that. So that's why, you know, the technology that we have is just, if he happens to get up and run across the house or walk across the house, whoever's sitting next to him generally just gets up and follows Zach around. So he's okay with that. One of the things I will mention, the video devices, they have infrared. So there's red LEDs that they can see at night. When there's two red LEDs staring at Zach, he's not really fond of that. So I tried to kind of hide it and turn it and put it in a different place, and we'll lay down in bed and he'll just zone right into it. Dad. So we kind of had to, you know, redirect. Let's change the subject. The SAMI monitor is full of infrared LEDs. So it's not two eyes. So I think he's okay with it, but it really is, you know, worth looking into those types of devices and think about the simplicity of them. And you know, tap into our community. Everybody within our community, they've used the device. So don't be afraid to get in those forums and ask those questions. So that's.
Sorry. Thank you so much, Jen and Rich. So I have a list of more questions, but since we're so behind on time, we can probably take like 1 to 2 questions from the audience. I wanted to give that chance first. So does anyone have a question for anyone on the panel before we go to break? Up front, we've got a question.
Quick question for Dr. Laux. You talked about preceding seizures when folks were in the EMU, and I'm curious how much preceding, like minutes, hours, like that we would see a seizure prior to a SUDEP incident.
Is this on? Okay. The seizures themselves, again, were not necessarily long in the terms of minutes, and it was soon thereafter the seizures, and I can't give you an exact number, although I can let you know later, but it was pretty quickly thereafter.
Thank you.
Question about the probability of SUDEP around age 6 and 7. Why there's a high peak around that? Because I have seen several researchers from Japan, Sweden, and the one that you just presented, there was a peak around 6 years old.
Different studies will show different things. So the one I showed was a peak at 1 to 3 years of age, and then there was some continued SUDEPs amongst the ages that followed, but then the second peak was around 18. So exactly why it occurs at different ages is not known. You can certainly theorize that in the early years, early childhood, when sometimes the seizures themselves are the most frequent, that could be a higher risk just because we know that they're so associated with, you know, the worsening seizures themselves. But as we heard from Tom, obviously, you can have SUDEP and actually have well-controlled seizures. And I have had families whose child died of SUDEP, and they actually were in the midst of their best seizure control
that they've ever had. So it is true that worsening seizures give a worsening risk of SUDEP, and you can certainly theorize that's why it happens kind of in the early childhood years at that age, although the one study I had showed, the highest peaks were 1 to 3 years and after 18 years. Why that happens at those different ages otherwise, it's hard to say. When you don't know why exactly something occurs like SUDEP, it's really difficult to say why some of these factors may be.
All right, I think with that, we're gonna have to move to break. So everyone can catch these excellent speakers during the break or during lunch if you have more questions. I think we've gotten to see an excellent clinical perspective. We've gotten Tom's excellent perspective and knowledge on devices, and you've learned about all the support Danny Did Foundation offers to families in acquiring devices, but also if you wanna know more about an individual device, their website is such an excellent resource, so I encourage you to go there. And then I think hearing from Jen and Rich sort of gave us more of the reality of practice and how important it is to have conversations with the other caregivers in the community to understand their perspectives while you're trying to decide what might work for you. So thank you so much to our panel. Let's give them a round of applause.